Good evening. My name is Steve Hernandez, and I'm the Executive Director of the Legislature's Nonpartisan Commission on Women, Children, Seniors, Equity, and Opportunity. We're here tonight to have a discussion in honor of the fact that this is Suicide Prevention Month in our country. The state of Connecticut, as several of you may know, and several of our members of the panel tonight will attest to, has really been tracking very closely the incidence of suicidal ideation and completion in the state of Connecticut and across the country. And over the past couple of years, we have seen the impacts not only of death by suicide, but also some of the ways in which we have chosen to respond, not only to the despair, but to that moment where intervention is necessary. Tonight, we will hear from subject matter experts. We hear from families and communities can come together to address despair. And we will also hear from our legislators who are actively working on your behalf, not only to bring the best information to you at any given moment, but to marshal those resources as we may need them. We have a packed agenda tonight, and we want to make sure that we reach as many people as possible with this message of hope in the face of despair. So we're going to get started. Firstly, welcome everyone who has joined us tonight. I do want to mention that there are several leaders with us on the screen who will be coming in and out tonight because of responsibilities that they may have in their own districts. These are, after all, leaders in community that are committed to their communities. So as they come in and out, we will be acknowledging them. I see here now we have Representative Christy Carpino, we have Representative Cook, we have Representative Kennedy. I also see that we have Senator James Maroney. As other leaders come on, we will acknowledge them accordingly. They are here to listen and they're here to learn as well. And thank you to CTN for covering tonight's communication. It's a critical public service to cover this message. And finally, to our friends on Facebook, please feel free to communicate with us as you hear tonight's information. So without further ado, I'd like to welcome our first expert panel. Tonight we will hear from Dr. Andrea June, Associate Professor, Department of Psychological Science at Central Connecticut State University, and Regina Dighton, Principal Investigator, Child Safety Forward Project for Trinity Health of New England. Welcome to our expert panel.
Hello,
Thank you,
great
everybody.
to be here.
Okay. Andrea, would you like to go first, please?
Sure, that sounds good. Yes, hello everyone, welcome. Thank you so much for the opportunity to be with all of you tonight to help raise awareness about the risk of suicide in older adulthood. So as it said, my name is Dr. Andrea June. I'm a professor of psychological science at CCSEO, and I'm the coordinator of our gerontology programs there. I am trained as a clinical psychologist who specializes in working with older adults and their families. And so that's the frame that I'll be bringing to our discussion today. So I'll open just by saying that older adults may face many ageist attitudes and even beliefs from others that they are old, so of course they want to die. So this is not a normal response to the challenges of aging. And so I really wanted to start with that first. Thoughts of suicide among older adults should never be dismissed as common or as expected. So talking a little bit about the statistics and the numbers. So older people are the demographic group with the highest rates of suicide deaths globally. In 2020 in the United States, the suicide rates were higher among older adults aged 75 to 84, with the highest actually among individuals 85 years and older. If we drill down a little bit further into this, we can see that older white males are actually at the greatest risk for suicide. While veterans age 75 and older have the lowest rate, as of statistics in 2018, the absolute number of suicides was among the highest for veterans age 55 to 74 years old. And that accounts actually for 40% of all veteran deaths by suicide. Projections indicate that older because of the older adults segment of our population growing, we anticipate that there will be more suicide-related behaviors as, again, our current cohorts mature into older age. Thinking a little bit about Connecticut, just about our aging population in Connecticut. Connecticut is the 7th oldest state in the country by median age. And at least 23% of our population here in Connecticut is over the age of 60 years old and increasing every day. So this is very relevant. Connecticut is home to the most diverse older population in New England. And in Connecticut, thankfully, the overall numbers of suicide are relatively low compared to the overall US population. And this is true for all age groups, including older adults, but still a very important conversation to be having. So thinking a little bit about the factors that are the risk factors that we think about for the characteristics of those who are dying by suicide, who are older adults. We think about them from the biopsychosocial model, and for ease of recognition, we refer to them as the 5 Ds of suicide risk in later life: depression, disability, physical disease, social disconnection, and access to deadly means. So talking a little bit about each of those pieces tonight and what we know about them with older adults. So mood disorders, especially major depression, are most common mental disorders among older adults. Who die by suicide. President that older adults are less likely to report feeling sad or depressed mood, and instead may describe more physical symptoms as their primary concern. Older adults who die by suicide are also characterized by physical declines in health a year before their death, morbidity, I always get stuck on that word, and poor sleep quality. What's interesting to note here is that the combination of depressive disorders and medical illness is particularly common among later life individuals associated with suicide. In terms of preventative efforts, we know that older adults who die by suicide are commonly seen by their primary care physicians in the months and weeks leading up to their deaths. So thinking a bit about the role of prevention, screening in primary care is super essential when we talk about catching people and getting them the treatment that they need. Again, thinking about risks, greater number of functional difficulties that the person has. So we talk about that as their activities of daily living or their instrumental activities of daily living, things that are necessary for maintaining independence. The more that individuals lose those abilities, the greater the risk. And then not a surprise to anyone, given all of the conversations that we've been having about social connection, especially in the wake of COVID-19, indicators of social disconnection are linked to suicide risk in later life, as well as suicidal ideation, attempts, and deaths. So this is living alone, smaller social networks, the absence of a confidant, the loss of a spouse or someone close to them, loneliness and social disengagement, participating in activities. And then the risk is significantly higher, knowing that older adults tend to use more lethal means, firearms, in their suicide attempts. So they're much more fatal among older adults. Older adults who use firearms by suicide method are more likely to live in rural areas and have served in the military. And so again, I just want to reiterate, having gone through those risk factors, that suicide in later life is not an expected or a normal response to aging. Rather, psychological research has demonstrated that later life is often characterized by a greater well-being, more positive emotions, and a better capacity to manage emotions. for those working with older adults and their loved ones in their lives, we need to remember to hold two truths at once. Older age can strengthen well-being and brings a wealth of resources to an individual. And at the same time, it can also be associated with a higher risk for suicide. So as I mentioned before, it's really important for us to do screening efforts. This is especially important for older adults as they're less likely to spontaneously report suicidal ideation. It is up to us to ask. I will say that one more time. It is up to us to ask. Suicide risk assessments are safe and do not cause or create suicidal ideation. You will not give the person the idea by asking the question. And so it is absolutely necessary that we ask. And as I mentioned before, because a majority of these suicide completers have visited their primary care physicians in the year before the suicide, primary care really is an ideal setting to identify suicide risk and initiate mental health care. Again, multiple screening tools are available and effective. We are often already using them. So it really just requires us to be mindful and to implement them with every older adult that we see. I'm often asked about the impact of COVID-19 on older adults, and in this case, particularly relevant to suicide. And so I often mention that the research that came out was surprising to some, in that many community older adults, dwelling older adults, actually experienced lower rates of anxiety, depression, PTSD, less negative and more positive affect, as well as more daily positive events, despite similar levels of stress that they were comparing to younger adults. So again, for the vast majority of older adults, they were able to manage and cope well with COVID-19, perhaps better than some of our younger cohorts. That said, across the board and in older ages is no exception. People of color, people with limited financial means, residents in nursing homes and other communal and living environments, and those living with dementia and their caregivers were more likely to see a greater negative impact and potential suicide risk. The data that's available for veterans specifically, as of the 2020 National Veterans Suicide Prevention Annual Report, suggested at this time anyway, there were also no increases in suicide-related behavior. So I'll wrap up this bit just by talking a little bit about treatment and the availability of resources. So we know that behavioral interventions and psychotherapies that are evidence-based for treating depression in later life can be useful for older adults at risk. Again, several empirically supported treatments are available. Again, that's another myth that we often see with older adults, is that the myth that all older adults are depressed. But no, depression is a clinical diagnosis, and older adults benefit from therapy as much as younger populations. We also know that addressing social connection can be useful for older adults at risk for suicide. Again, in the context of social isolation, loneliness, creating a connection plan, connecting older adults to community services, again, through the Area Agencies on Aging, AARP's resources on social isolation, the National Resource Center for Engaging Older Adults. And again, in the case of disability, sensory impairment, physical illness, or pain, if those are pieces that are contributing to suicide risk in older adults, it is very important to connect to a primary care physician to be able to address those. Nobody of any age should be in pain or unable to navigate their environment. Assistive technologies exist, and we should use them. Yeah, so I think I'll stop here maybe and see what what Regina would have to share.
Thank you so much. Hi, thank you so much, Andrea. This is Regina Dighton, as you see on the screen. And yeah, I'm listed here, which is true, as the principal investigator of a demonstration project funded by the U.S. Department of Justice. It's a grant I wrote to reduce the preventable death of children. And we're focused in Hartford. And we're actually wrapping up the demonstration project now and hopefully, really hopefully gaining funding to continue this project in Hartford and throughout. So we've done very well. That was one of our parents who joined on this link instead of the other link. In addition to that, I'm an adjunct faculty at the UConn School of Social Work, where I teach something called the Urban Semester Seminar, working with students who are interested in working with students in urban areas. And my MSW is in community organizing. So I come very much from that community space. And what's been unique about the project, and I will get suicide, what's been unique about the project of the 5 demonstration sites in the US is it's the only one to be centered in community power and parent power. And in that, we've got a few principles that I think definitely relate to suicide prevention. One is the nothing about us without us. And another one is the people closest to the problem are closest to the solution. And that experts, whatever that means, should always plan with people and never for people. And out of that, I really try as a human being and in my work to bring my whole self to my work and encourage all of us who work in any way to support human beings, to bring our whole selves so that we can welcome the whole selves of others. And one of the ways that I often do that is with my writing. All the other things I said, I'm a writer. And so I'm going to share 2 short pieces with you. They're actually a piece of a piece that I wrote in response to the suicide of my ex-late husband, who took his life in 1989. And the first one is called You Will Miss the Millennium. You will miss the millennium and the class of 2000, Edward and Raina's graduation year. You will miss weddings and grandchildren and the everyday beauty of washing dishes, feeding dogs, petting cats, and arguing with loved ones. You will miss growing old. I look forward to knowing you in old age. The last 20 years since we divorced had brought us wisdom and friendship, priorities, and the foolishness of finding blame. Perhaps you will see us from where you are. Perhaps you will be present and miss nothing. Surely, my darling, we will miss you. The second one is simply titled Memory, second part. He used to scare me like thunder and lightning until he hung himself. I never thought he was the one afraid. Never thought I was the one brave. And ever since I cried over him in that cardboard box, shipped like a fish on ice back to Jersey, I cried all over his hospital pajamas, pulled up the sheets he was wrapped in, and touched places I hadn't seen in 20 years and remembered. Seems that since then, all I remember is romance, the intense freedom of early love, hazy sunset, and making love, except when it storms. It scares me like thunder and lightning. So I want to start my presentation by rooting myself in remembering where I come from and remembering that suicide is horrible, the person who takes their life, but how it affects, never stops affecting. You know, we can heal, we can be very well. I'm one happy 69-year-old woman, you know, but we still look at the effects in myself and my now adult children. So with that, I thank you for making room for my whole self. And now I will act more scholarly. In looking, you know, and being asked to do this and thinking about it with parents and taking a look at the data, which is, you know, something I do. You look at the data. I was skimming it, to be honest. One of the things that frankly got on my nerves, I realized the importance of acknowledging specific communities. But when I tried to look at why do ethnic minorities commit suicide, how does that happen? I found something for Black, and Black always came up first. And then it would be, you know, labeled as Hispanic. And then you'd have to search in the corner somewhere for AAPI. And yeah, I'm kind of sick of that. The parent group has been primarily African-American and Latinx. And we've been talking about ourselves as not wanting to, like, I want to criticize, I guess, the constant research looking at Black and white as if there's no one else. There's so many other folks who've been around for the longest time. So when it comes to things that affect many, many communities, I think it's just really important that we look at them and work at them together. So apologizing first, I'm going to talk about some of the data that I found, and then I'm going to attempt, or I've attempted, to kind of look at how it affects us all and what we could all be doing, you know, and how we can support one another. We should certainly be supporting one another just to be able to keep living. The American Academy of Child and Adolescent Psychiatry in 2022 looked at, as is seen many, many places, that right now looking at Black youth, suicide is the second largest cause of death for 10 to 19-year-olds, and that the rates among Black youth have risen faster than any group in the past 2 decades, according to them. Another one will say Hispanics rose more, blah, blah, blah. But anyway, it rose 60% in Black males ages 10 to 19. And for those 12 and under, they were twice as likely to die in suicide as their white peers. It's, what can I say, that's so sad. And that Black youth are less likely to receive follow-up outpatient treatment after a suicide attempt as their white peers. Looking at the suicide rate amongst Hispanic adults from 2010 to 2020, it increased by more than 70%, while the population of Latinx people, that's my preferred term, in the US grew 25%. Population grew 25%. The rates of suicide grew more than 70%. Also within that time from 2010 to 2020, the means of suicide changed. In 2010, it was more by hanging. As we got to 2020, it was more by firearms. And among Latinx adults, they found that firearms were the second leading cause for women, not cause, method for women, and the first method used by men. Now, the study that was referenced here in this article in Health Day News by Cara Murez was looking mostly at Latinx populations in the Midwest. I don't know if it applies here, but one of the things that she noted was that Latinx men, the purchase of guns during the pandemic was disproportionately high, significantly more likely were Latinx men to buy a gun than other populations, and that those gun purchases continue to rise. I don't know if that's the case in the Northeast, and suicide rates are less here, but I think it's definitely important to be looking at gun safety, gun storage, especially when we talk about our teenagers and our young people, and gun control, gun access. Throughout the US, about half of all suicides are by gun amongst all populations. Now, I want to talk about intersectionality because I think it's first of all, it's reality. Few of us, if we really think about it, only have one identity. We're all in some intersection. We're male in something, we're female in something, we're trans in something, we're non-binary and something. 1 in 3 Black transgender youth attempted suicide in 2019, according to the Trevor Project, which is a crisis intervention and suicide charity for queer youth. Black queer youth are even less likely than Black cisgender heterosexual youth to receive mental health services, much less services that attend to their racial, cultural, gender, and sexual orientation identities. Black, trans, and non-binary youth seriously considering suicide, that rate is double that for their white counterparts. And they are way less likely to get mental health services. Now, suicide isn't the only reason, but I like to inform people wherever I can of the seriousness of this crisis of queer Black lives just continuing to live. The life expectancy of a Black transgender woman in the United States is 35. Some of that suicide, much of it is murder. But I just want to put that there. It's 35. It doesn't fare much better for Latinx, for Asian, transgender women either. And so when we have to ask ourselves why. And for me, what's important is what can communities do and how should we all be working with communities? I want to assert that communities should lead. In the Child Fatality Reduction Project, I and some colleagues, which included a parent, presented our project at a conference in Baltimore, Maryland, about a week and a half ago. And one of the project directors from the Department of Justice noted, not for the first time, that rates of child injury and fatality for all reasons and abuse and neglect had not gone down in over 2 decades. They just stay the same. She said she believed they really would go down if we looked at the model being used here in Hartford of centering power in the communities most affected. I think that this applies to suicide as well, that it's real important for communities who are affected, individuals who are affected, to come together as communities, to be able to say to all of us on this call and others beyond who are policy, who's focuses in policy or service or whatever it is, direct service, advocacy, to say, this is how we need you to help us. This is what we need from you. They know why there's a disconnect between their community, their family, and mental health services. They know what they've gone through to get there, and we have to make it safe for them to tell us. We have to make it safe for people who are living in the intersections of a busy crossroads that's running them over. Those who are, some of the reasons they look at for the suicide rate in children, children of color here that I talked about, and adults in racial and ethnic minority communities are one, in terms of intersectionality, we have higher rates of disability. You know, Andrea talked about the Ds. Well, queer people have higher rates of disability. It's 20% in the general population, up to 25% in queer communities, and up to 25% in communities of color. I don't know what it is for somebody who's a queer person of color with some other intersections coming in there. I don't know, but it gets higher. So that's one of them. Also, you know, amongst youth, we look at bullying, LGBTQ discrimination, the number of trauma, and racism. That children of color are less likely to be diagnosed with a mental illness. They're more likely to be seen as a behavioral problem and to receive punishment over treatment. I already mentioned that fire safety and firearm safety is an issue. Family and community rejection, perceived and real, is really important here. We need affirming, welcoming spaces within our communities, and we need to be building them. And that gives me a chance to raise up a great project that I think should be supported, expanded, and I'm not on their board or whatever. I have no financial interest, but I just want to point out Project Kiki, which is a project of Latino Community Services. And the thing I love most about them is that they're right in the heart of the communities that they serve, openly loving and welcoming queer people of color to receive services around mental health, addiction issues, and all kinds of needs. A vision of mine, and one of the things I try to do wherever I can, including starting a ministry at the Metropolitan Community Church, it's the LGBTQ church, is there's a ministry we call TV 365, Transgender Visibility and Voice, 365 days a year, to reach out and provide some of those life-saving measures of all types of support to transgender people, particularly transgender people of color in Hartford, that are often just doing without basic needs. Each and every one that I've spoken to has attempted suicide at some point, and including the youth, who've said that simply having support has meant a lot to them. Within our communities of color, some of us still see mental health as either a spiritual or religious failing or just overall general weakness. So once again, I think that as we listen to communities, they can say more to us about how we can help to mitigate that. And no, you can't guarantee to change anyone or any groups of ones, but what we can do, I believe, is kind of be like Project Kiki and be there and say, we are folks who look like you, feel like you, eat like you, cook like you, and are there to support you. You know, we have to gather up the supporters and make ourselves very, very visible. Finally, I want to close by saying that I think the political climate in which we're seeing anti-trans healthcare legislation, you know, threats to reproductive care for women are certainly added pressures for people who are already depressed, already wondering if they should continue living, and that we've got to be, I think, really, really dedicated and strong at this time. I'm proud to live in Connecticut, but we really need to, step up and know that even though we're in Connecticut, don't take the current status for granted, to, pay attention. It's not like all of the haters are somewhere far away. And that these young people, these young people, these queer young people, they can't vote. They cannot vote. I let them know every time I'm around. I vote. I'm telling everybody over 18 to vote, and we're voting to help support you and, equity for all people, all times, all places. And thank you for listening to me and making room for my whole self.
Regina, thank you so much. And thank you for your powerful words. Both you and Andrea just really bringing us just a snippet of how it is that despair can manifest itself, whether it is throughout the life cycle or whether it is because of a recent experience or recent trauma or because of feelings of isolation, all of the different ways in which someone may experience despair in their community at any given moment. These are the things to look out for. It's the things to question about when you're following your question and refer methodology in addressing immediate despair. Those are the things that you're really looking for, is where those specific vulnerabilities that people may be exhibiting at any given moment. Thank you for discussing the intersectional vulnerabilities. I think it's important also that it's our job to ask. That really resonated with me, June. And not to expect that just because someone is older or just because someone is going through a particular era of their life, that suicidal ideation is normal. Or to be normalized, I should say, and to find yourself intervening in ways that are informed. Next, I want to question, persuade, and refer. Of course, is what I was trying to bring to mind. Question, persuade, and refer. Our QPR training that we've received not only here in the past, but continue to receive in community. Mui, I'd like to ask you if you would. Come to the fore and be our next presenter, going a little bit out of order of the agenda. But I just think before we go into the resources, it makes sense to touch upon the different areas of statistical significance where people do experience suicidal ideation. We also think about, we think of the era of youth, as some of you describe. We think of the era of special populations, people with different intersectional identities or moments in their lives. But also later on in life, we think of the resurgence of suicidal ideation among middle-aged men, what that looks like, and again, the elderly and the comorbidity conditions that you described, Andrea, are also really compelling and things to look out for. Welcome, Mui Hin McCormick.
Thank you so much, Steve. And once again, thank you to the Commission for allowing this opportunity for us to really have a conversation and delve deeper into some of the communities. Andrea, thank you so much for your presentation and information regarding older adults and things that we need to be mindful of. Regina, so nice to see you. It's been a long time, but very nice to see your friendly face and still seeing that you're doing great work on your end. And I think after my presentation, there will be themes that are very similar that I think everybody can really pull together as to heeding caution and really mobilizing our communities to come together and take some action. So I'm going to go ahead and share my screen. Okay, so everybody should be able to see that. I'm Mui Hin McCormick, and I am a clinical director over at Rushford Center. In addition to being clinical director, I'm very actively involved in our AAPI community. AAPI stands for Asian American and Pacific Islander. I'll be referencing that quite a bit throughout my presentation. I also chair the AAPI subcommission that is part of the Commission on Women, Children, Seniors, Equity, and Opportunity. And I am also vice chair of our nonprofit, APAC, which is Asian Pacific American Coalition of Connecticut. So I wanted to start off with sharing some AAPI demographics. I think it's really important for us to be able to understand what our demographics are when we're then, focusing on suicide in an underserved community like the AAPI community. So how many countries are in Asia? I think people can guess a variety of different numbers. We have about 48 countries within its borders that are recognized by United Nations. There are also 5 additional dependent unrecognized territories that are within the Asian continent. How many languages are spoken in Asia? Asia is home to about 4.46 billion people, quite a lot of people, right? Speaking about 2,300 languages. Let me repeat that. Speaking about 2,300 languages. That is a significant amount of languages spoken throughout Asia. And as you could see, I indicated top Asian languages spoken. You have Chinese, Hindi, Indonesia, Bengali, Japanese, and the list goes on. I identified 10 of them. So separating geographically, Asian Americans and Pacific Islanders can be broken down into 4 geographically based groups. You have Pacific Islanders, mostly Native Hawaiians, Samoans, and then you have Southeast Asians, largely comprised of Indo-Chinese from Vietnam, Thailand, Cambodia, Laos, Philippines. You also have East Asians, which I think are a lot of people definitely hear about in the news, the Chinese, Japanese, Koreans. You have South Asians, including those from Bangladesh, Bhutan, India, Pakistan, Nepal, and the list kind of goes on. Now let's look at United States and Connecticut AAPI demographics. In the US, 2020 Census Bureau estimated 24 million AAPIs. You have AAPIs comprising of 5.6% of the total population, over 10% of resident population in 5 states. Population growth from 2010 to 2018 is 25%. So that's also another significant number. Population growth of AAPIs from 2010 to 2018 is 25%. 66% are foreign born. And that's another significant number to pay attention to. 66% of AAPIs are foreign born. And then you have Census Bureau projecting increase of 41 million by 2050. So that would comprise of about a little over 9% of the US population. What are the 3 top counties in Connecticut with the highest AAPI population? I get that question quite often. Connecticut population, a little over 3.6 million. You have Connecticut APIs, which represent 4.5% of Connecticut population. 74% are foreign born. Let me repeat that statistic. Nationally with 66%, Connecticut is 74% are foreign born. Top 3 Asian populations by county, you have Fairfield as the highest, Hartford next, and then New Haven. Largest AAPI groups in the United States in 2018, you have Chinese topping the list, Asian Indians, Filipinos, Vietnamese, Koreans, and Japanese. States with the biggest AAPI populations, California, New York, Texas, New Jersey, and Washington. Largest AAPI groups in Connecticut, Asian Indians, Chinese, Filipinos, Vietnamese, Koreans, and Japanese. I am throwing a lot of information out, and I do apologize for the information that is being presented, but I think it's really important for everybody to understand the overall picture of where our landscape is compared to the United States and Connecticut. So top 10 cities in Connecticut with the highest AAPI residents. I wanted to highlight the increase. So we have New Haven, the percentage increased a little over 54%. Manchester, percentage increased a little over 36%. South Windsor, the percentage of AAPIs residing in South Windsor increased at 138%. Hartford, the percentage increased almost at 26%. AAPI National Suicide Statistics. So race-based issues that I think everybody really needs to be more educated and aware on. You have the model minority myth, and this really frames Asian Americans as the racial success story, and it also pits minority groups against minority groups. This really coined back in the 1960s when you had the whole issue with the Japanese internment camps and the Japanese Americans being termed as the model minority, not causing any problems or issues. other minorities were, either protesting or, expressing themselves in different ways. Perpetual foreigner stereotype, it really speaks to no matter, so regardless of if you're born in the United States or not, because of the way you look, you will always be considered a perpetual foreigner. So regardless of if I was born in the United States, there is nothing that I can do because of the way I look and how I am perceived. I will always be seen as a perpetual foreigner. This really hits home to a lot of our youth who are born in the United States and really identify American first, Asian second, but they are still considered as foreigners. You have generational trauma. This really speaks to a lot of the post-war, what was going on in the 1970s and 80s with refugees coming to the United States because of war-torn countries and political, things that were going on there. Generational trauma is really passing on trauma to the next generation. A lot of times in our Asian community, it's passed on from generation to generation because it's never addressed. It's never identified, it's never diagnosed. People aren't receiving services, they're not accessing services. You then have stigma. The Asian American group is the least likely racial group to take action on their mental health. And that is a huge, point that we need to be mindful of. Asian Americans are not seen a lot in mainstream services, and there are reasons behind that. To Regina's point that she indicated before, there's a lot of the cultural environment piece that we're not taking into consideration as mainstream providers. Just because we are not accessing services, we are then not counted towards statistics and data. And Regina spoke about this in the beginning too, is the Asian American group is really, there's no data in Connecticut regarding suicide in the Asian community. A lot of the information that I was able to find was really just national statistics. And even then, that was very difficult to find. And we don't have a lot of recent studies, and we don't have a lot of, recent information to really draw from. So that really speaks to a gap and barrier that we have within just one population. And this speaks true to other underserved minority groups as well, too, not just the Asian group. You also have expectations. The Asian community, there's a lot of expectation that is being put as pressure on the individual, whether it's a family expectation, community expectation, individual expectation. Cultural considerations, language, right? If I am not speaking English or English is not my primary language, why on earth would I seek mainstream services that don't speak my language? Why on earth would I seek resources that aren't culturally and linguistically appropriate? They won't understand. That's my belief, right? Is they won't understand where I'm coming from, what I'm going through, because they don't understand my culture. They don't know my culture. These are just some things that really come up quite a bit when we talk to community members. Health literacy. That's a huge gap in our community as well. Family structure, values, traditions, religion. According to SAMHSA's National Survey on Drug Use and Health, mental health issues are on the rise for AAPI young adults. Another point that Regina spoke about is youth. Our youth are definitely rising when it comes to various mental health issues. Serious mental illness rose, from 2.9% to almost 6% in AAPI people between 18 and 25, and that was between 2008 and 2018. You have major depressive episode increased as well too. Despite having a 17.3% overall lifetime rate of developing a mental illness or psychiatric disorder, Asian Americans and Pacific Islanders are 3 times less likely to use mental health resources. That's a huge statistic that we need to really pay particular attention to, right? You have a high number rising of individuals developing mental health or psychiatric disorder, but many AAPIs not seeking services or resources to address those pieces. Suicidal thoughts, plans, and attempts are also on the rise among AAPI young adults. While it's still lower than the overall U.S. population, aged 18 to 25, you have 18 to 25-year-old serious thoughts of suicide in 2018 compared to 7.7 in 2008. Statistics on Asian American suicide-related outcomes. Suicide was the 8th leading cause of death for Asian Americans, whereas the 11th leading cause of death for all racial groups combined. Suicide was the 1st leading cause of death for Asian Americans aged 15 to 34, 2nd leading cause of death for American youth. Among all Asian Americans aged 20 to 24, the highest suicide rate was almost at 13%. Among females from all racial backgrounds between the ages of 65 and 84, Asian Americans had the highest suicide rate. U.S.-born Asian American women had a higher lifetime rate of suicidal thought. Among Asian American adults aged 18 to 34, highest rates of suicidal thoughts at almost 12%, intent at 4.5%, and then attempt at almost 4%. Asian American college students were more likely than white American students to have suicidal thoughts and to attempt suicide. National study found that compared to Latinx, Latinos, Asian Americans with suicidal thoughts were less likely to seek help and perceive a need for treatment. So once again, the theme continues of AAPIs not feeling comfortable for one reason or another or seeking services. Anti-Asian racism in response to the COVID-19 pandemic and after the 9/11 attacks further compounds the mental health concerns, and that has significantly impacted our communities. We've all heard about anti-Asian racism, discrimination, hate crimes. We've seen it, covered in the media. And I always educate people because when we started to see it in the media, that's when people were more aware and questioning and wanting information. But then they were saying, wow, this is all started because of COVID-19. I reminded folks that this was years, decades before COVID-19, right? Asian Americans have been dealing with discrimination, hate crimes, all the way back to the 1800s. So this is not new news. It's new news to some people who haven't been educated or aware of what has been going on in this community. Risk factors. Mental illness. Presence of depressive and anxiety disorders is one of the best predictors for suicidal thoughts. Social factors. Family conflict. Viewing oneself as a burden to others. Experience of discrimination predict increased suicidal thoughts and attempts. I think for our senior elderly population in the Asian community, they really do feel like they are a burden to others. They're a burden to their family. Chronic medical conditions. Men with chronic medical conditions are at greater risk for suicidal thoughts than those with chronic medical conditions. Protective factors, ethnic group identification. Strong identification with one's ethnic group is a protective factor against suicide attempts. Social factors, family conflict, viewing oneself as a burden to others, experience of discrimination, family cohesion and support. Strong family cohesion and parental support are protective factors against suicidal thoughts for adults and adolescents. Regina also mentioned the Trevor Project, and I was able to find some really good information through one of the reports through the Trevor Project as well too. 40% of AAPI LGBTQ youth seriously considered suicide in the past year, and this is a report that was released back in April of this year. 49% of Pacific Islander Native Hawaiian youth, 47% of Korean youth, 41% of Filipino, 39% of Indian youth, 31% of Vietnamese, and 29% of Chinese. These statistics are alarming and so important for us to realize what is going on with our youth population. 16% of AAPI LGBTQ youth attempted suicide in the past year, including 20% of Pacific Islanders, 18% of Korean youth, 14%. So you could see these numbers, they're really alarming. 41% of AAPI LGBTQ youth were not out to at least one parent about their sexual orientation, compared to about 29% of overall sample of LGBTQ youth. So when you break down the AAPI, it's broken down into 60% of Vietnamese youth, 55% of Indian youth, 49% of Chinese youth, 43%. These numbers are high. So out of the 41%, these ethnic groups are finding it even more difficult to really, be open and honest with their family. AAPI transgender and non-binary youth reported significantly higher rates of suicide risk compared to cisgender. half of whom seriously considered suicide, and more than 1 in 5 reporting a suicide attempt in the past year. Protective factors unique to the AAPI LGBTQ youth: strong connectivity to one's cultural background. You also have parental acceptance of their sexual orientation or gender identity. But if they're not coming out to their family, then they're not able to get that support, right? They're not able to see their family as a resource and support. You also have AAPI LGBTQ youth who have supportive family and friends, and access to LGBTQ affirming spaces reported lower rates of attempting suicide. Treatment issues. Language barriers make it difficult for Asian Americans to access mental health. I keep on saying that throughout the presentation. You have almost 33% Asian Americans not speaking English fluently. Discussing mental health concerns is considered taboo in many Asian cultures. Because of this, Asian Americans tend to dismay, deny, or neglect their symptoms. Lack of awareness of the resources and services that are available, as well as the stigma surrounding mental health issues. You have limited data that we were mentioning already. Most young Asian Americans tend to seek out supports from personal networks such as close friends, family members, and religious community members rather than seek professional help for their mental health concerns. Historically, AAPIs have had challenges in accessing health care and insurance. You have almost 7.5% of Asian Americans and 9.5% of Pacific Islanders don't have health insurance. Overall, AAPI adults are the racial group least likely to seek mental health services, 3 times less likely than their white counterparts. And then AAPI adults with mental illnesses, 73% did not receive treatment compared to almost 57% of the population. Recommendations: determine the language preference, offer interpretation services, translate materials. And when I suggest this, I don't mean to translate, materials in 100 different languages. Really know what your community is and find out information from your community. If you're supposed to be serving a specific region, go into your community and identify what the top 3, if that's what your resources are able to. If you have more resources, maybe you can identify the top 5 Asian languages that are spoken more, or AAPI residents in that region. Be open to learning about cultural beliefs and practices. Attempt to understand and accept cultural beliefs and practices when working with that individual and our family. This is really an important one for mainstream providers, right? It's not our task to really judge, and I think depending on how we approach things and respond and react, we may be perceived as judging. So I think it's really important for us as providers to ask. Each person is an expert on themselves. Each community is an expert on themselves. And if you don't know or not educated or aware of a specific community, ask those questions. Community members welcome people asking questions. Listen to the client-patient's perspective. Acknowledge differences and similar views about issues and illnesses. Communication strategies. Message needs to be direct, but not too much detail. Be flexible in the way you structure questions. Explain and explore options and preferences. Interpret your views of treatment using words and concepts that are consistent with the client-patient's model. This isn't isolated to Asian Americans. It's really being person-centered, client-centered, right? It's about meeting an individual where they're at. Recommend and negotiate. Community outreach and engagement. And when I say community outreach and engagement, it literally is outreach and engagement. You have to leave your office. You have to go into the community. You have to learn about the community. You have to try to partner and collaborate with community leaders, provide education and awareness. And one of the most important things is collecting data. Include AAPI demographics in questions. Break things down demographically as well too. Instead of clumping Asian Americans as one, break it down into specific ethnic groups. And that really helps us be able to, identify additional barriers or issues within our Asian communities. Okay, so I will stop sharing. And like I said, I do apologize for just the information that was being shared, but I really felt like it was important to be able to connect those dots as to setting the platform and then being able to really speak on some of the issues in the community. Thank you.
Thank you, Mui Mui. One thing that's really compelling about each of your presentations is how, and I appreciate your generosity in sharing the statistics, because I think across communities, some of these pressure points resonate, even if you talked about the model minority myth, right? And look across the state and how much pressure is put on young people because they're supposed to do well or because they're expected to do well, right? Whether it's through a model minority myth or it's because you're in a high performing district, right? Where all kids are expected to do really well. And there are those kids who just feel like they're left out, like they're not living up to the standard. So it's another thing to look for when you're engaging in a QPR moment, or when you're using some of the tools and resources that are available to you to help intervene in a particular moment. So we appreciate that, Muy Muy. And I hope that this is resonating with those of you who are viewing, but also those leaders here. Let's take our next step now is that we're going to hear about some of those resources, maybe a few more statistics, but some of those resources that are available to you. You know, there's some great work that's been going on at the United Way of Connecticut over the last few years now that's culminated in the most recent tying together of 211 and national resources. 988 comes to mind, which is the new national hotline for those who are experiencing despair and suicidal ideation. So I'd like to call to the fore now Solimar Vasquez. Solimar is at the United Way, where she serves as Diversity, Equity, and Inclusivity Coordinator for the United Way of Connecticut. Solimar is going to be providing some of those resources, suicide resources that I mentioned, and perhaps some statistics that you may be gathering in your work at the United Way. Solimar, welcome.
Hello, everybody. Good evening. I am going to be sharing my screen because I did provide a presentation. I do have resources. I also put in statistics because I kind of wanted to give everybody kind of like a background on how suicide affects, you know, the military, people of color, you know, and different marginalized communities, as well as the resources we have available. So if you give me 1 second, I can start sharing my screen. Right here. Okay. Can everybody see my screen?
No, we can't.
Okay. Yeah. Can you guys see my screen now? Okay, perfect. All right. So suicide defined is when people harm themselves with the goal of ending their life and they die as a result. Suicide attempt is when people harm themselves with the goal of ending their life, but they do not die. It is a serious public health problem that can have lasting harmful effects on individuals, families, and communities. People of any age, race, ethnicity, or sex can experience suicide risk, but certain groups have substantially higher rates of suicide than the general US population, to include 13.9% per 100,000. And in 2020, suicide was the 12th leading cause of death overall in the United States, claiming the lives of over 45,900 people. And suicide is complicated and tragic, but it is often preventable. Knowing the warning signs for suicide and how to get help can help save lives. I'm going to be discussing some of the risk factors associated with suicide. It's rarely caused by a single circumstance or event. Instead, a range of factors at the individual, relationship, community, and societal levels can increase risk. And these risk factors are situations or problems that increase the possibility that a person will attempt suicide. Individual risk factors include previous suicide attempts, history of depression and other mental illnesses. I'm sorry, I'm a little under the weather, so my voice is kind of scratchy right now, so I do apologize. Serious illness such as chronic pain, criminal legal problems, job financial problems or loss, impulsive or aggressive tendencies, substance misuse, current or prior history of adverse childhood experiences, a sense of hopelessness, violence, victimization, and or perpetration. In the relationship risk factors, there could be harmful or hurtful experiences within relationships that also contribute to risks, such as bullying, family or loved ones' history of suicide, loss of relationships, high conflict or violent relationships, and social isolation. In the community, lack of access to healthcare, suicide cluster in the community, stress of acculturation, community violence, historical trauma, and discrimination. Societal risk factors include cultural and environmental factors within the largest society that do contribute to the risk. And it is stigma associated with help seeking and mental illness, easy access to lethal means of suicide among people at risk, and unsafe media portrayals of suicide. Okay. Then, racial and ethnic differences in suicidal behavior and mental health service use among US adults in 2009 and 2020 from the National Survey of Drug Use and Health consisted of non-institutionalized US civilians aged under 18. And in this particular study, they compared proportions of white, Black, and Hispanics among adults reporting no past year suicidal thoughts or behavior or suicidal ideations or suicide attempts. And multivariable adjusted analysis were used to evaluate the independence of observed racial ethnic differences in past year suicidal ideations, suicide attempts, and mental health service use. In the entire sample reported in the past year, suicidal ideation only and 3,661 or 0.9% reported suicide attempt. Compared to white individuals, Black and Hispanic individuals were significantly less likely to report past year suicidal ideations or 0.75 respectively, were more likely to report a past year suicidal attempt even after a multivariable adjustment. Black and Hispanic individuals were significantly less likely to use mental health services, but the lack of significant interactions between race, ethnicity, and suicidal ideations and suicide attempts in association with service use suggest differences in service use and do not account for differences in suicidal ideations or suicidal attempts. While suicide rates have recently declined for white individuals, rates among Black and Hispanic individuals have increased. Yet little is known about racial or ethnic differences and precursors to suicide, including suicidal ideation and suicidal attempts. Black and Hispanic individuals are significantly less likely than white individuals to report suicidal ideations, but more likely to report suicidal attempts, suggesting differences in suicidal behavior across race and ethnicity that may be impacted by socio-cultural acceptable expressions of distress and structural racism in the healthcare system. I'm gonna touch upon suicide rates in the veteran community because I noticed we didn't really talk about that much. So I was able to find information about suicide amongst veterans. In 2018, the VA launched the National Strategy for Preventing Veteran Suicide, which represents a comprehensive public health approach to veteran suicide prevention. This approach includes the use of both clinical strategies and community-based strategies with the goal of reaching all veterans, including those without recent VA contact. From 2018 to 2020, adjusted rates for veteran suicide fell by 9.7%. With the onset of the COVID pandemic in 2022, age and sex adjusted suicide rates among veterans fell 4.8% from 2019 to 2020 versus a 3.6% decline among non-veteran US adults. In 2020, there were 6,146 veteran suicide deaths, which was 343 fewer than in 2019. The unadjusted rate of suicide in 2020 among US veterans was 31.7 for 100,000, Over the period from 2001 through 2020, age and sex adjusted suicide rates for veterans peaked in 2018 and then fell in 2019 and 2020. From 2018 to 2020, age and sex adjusted suicide rates for veterans fell by 9.7%. In each year from 2001 through 2020, age and sex adjusted suicide rates of veterans exceeded those of non-veteran US adults. The differential in adjusted rates was smallest in 2002, when the veteran rate was 12.1% higher than for non-veterans, and largest in 2017, when the veteran rate was 66.2% higher. In 2020, the rate for veterans was 57.3% higher than that of non-veteran adults. In each year from 2001 through 2020, age and sex adjusted suicide rates of recent veteran VHA users exceeded those of other veterans. The differential in adjusted rates was smallest in 2018, when the rate for recent veteran VHA users was 9.4% higher, and largest in 2002, when the rate was 80.9% higher. In 2020, the age and sex adjusted suicide rate of recent veteran VHA users was 43.4% higher than other veterans. In 2020, suicide was the 13th leading cause of death amongst veterans overall, and it was the second leading cause of death among veterans under age 45. I also did bring up a couple statistics about suicides amongst adolescents, because they're another community that is affected by suicide. It's the third leading cause of death in young people ages 15 to 24. The CDC reports that boys are 4 times more likely to die from suicide than girls. Girls are more likely to attempt suicide than boys, and guns are used in more than half of youth suicides. And the causes of a teen to attempt suicide is basically the teen years are a stressful time because they are filled with major changes. These include body changes, changes in thoughts and changes in feelings, and strong feelings of stress, confusion, fear, and doubt that may influence a teen's problem solving and decision making. He or she may also feel a pressure to succeed. And for some teens, normal developmental changes can be very unsettling when combined with other events such as changes in their families, such as divorce or moving to a new town, changes in friendships, problems in school, or other losses. These problems may seem too hard or embarrassing to overcome, and for some, suicide may seem like a solution. A teen's risk for suicide varies with age, gender, and cultural and social influences. Risk factors may change over time. They are one or more mental or substance abuse problems, impulsive behaviors, undesirable life events or recent losses, such as the death of a parent, family history of mental health or substance abuse problems, family history of suicide, family violence, including physical, sexual, or verbal or emotional abuse, past suicide attempt, gun in the home, imprisonment, exposure to the suicidal behavior of others, such as from families or peers, in the news or in fiction stories. And finally, I'm gonna speak a little bit about suicide prevention resources, because as important as it is to talk about the statistics and how suicide affects different communities, it's also important to bring up the resources available to people who are struggling with ideations, with suicide, and are in need of mental health services. So the updated suicide crisis line is 988. It's a United States-based suicide prevention network of over 200 plus crisis centers that provides 24/7 service via a toll-free hotline with the number 988. It is available to anyone in suicidal crisis or emotional distress. And I believe it was recently just updated. So this is the newest updated suicide crisis line, because I believe the national suicide line was a 888 number before, and they just updated this to that. There is a crisis hotline. There's also 988lifeline.org. You can call or text 988, chat 988, lifeline.org. Veterans can press 1 when they're calling. You can actually text because there's actually a text line. You could text talk to 741-741. And there's also another Veterans Crisis line that is available to text at 838-255. Those are the Vets for Warriors. There's substance abuse mental health treatment referral hotline, which is 1-800-662-HELP. There's the RAINN National Sexual Assault Hotline, which is 1-800-656-HOPE. There's a National Teen Dating Abuse Helpline, 1-866-331-9474. And the Trevor Project, which is 1-866-488-7386. And finally, the local resources for mental health and suicide. As you know, we do provide services for that kind of work with 211. So if you live in Connecticut, you can dial 211 and be connected to a crisis specialist. If you are ever having a hard time, they also provide different resources for mental health, housing, and different things. I did list both websites there. The website is uwc.211connecticut.org. There's also resources with the Department of Mental Health Addiction Services of Connecticut. I did list that website as well. It's CT government website. And PreventSuicideConnecticut.org is actually website that I came across that also has resources with different groups who specialize in helping with suicide awareness and prevention. There's a lot of educational people plugged in and different resources available to veterans and different people in different lines of field that have a vast array of knowledge that actually helped me compose this presentation with the information that they provided. So, very, very, very special recognition to, those resources there. September is National Suicide Prevention Month. The National Suicide Awareness Week was September 4th to September 10th. We did recently do a walk this past Saturday. Connecticut United Way did recently participate in a suicide awareness walk. I'm pretty sure there will be pictures and a social media blast once more pictures and publications are made. And lastly, in a world where you can be anything, be kind. That's the simplest and easiest way to help somebody. You never know what a simple smile or a simple, hey, how you're doing can help somebody in need. And that is it. Thank you so much, Stephen.
Solimar, thank you so much for that. I think we can't overstate the fact that there are moments and situations, moments in the life cycle and situations that people may go through that really make them more vulnerable to suicidal ideation and attempt. And what's wonderful is that you've provided the examples of those moments that we should be looking out for, but also those situations that perhaps with a little bit of prevention and the right intervention, we can help save lives. Solimar, can you tell us just a little bit before I want to open up the floor for some reflections from our leaders, but can you tell us a little bit about QPR training, question, persuade, and refer training, and what that means for the benefit of our viewers who may not know what that is, and where we might find some of that resourcing?
QPR training, question, so that's a training that's taught to a lot of people who work in crisis services. And basically that training is literally what it says. You question, you question, and you persuade and you refer. So when a person calls you in crisis, you kind of have to do your best to calm them down and to remain leveled. And then you kind of, it's almost like you're kind of trying to talk them off of the ledge and you persuade them. And then based on the services that they may need, you would refer them to what services are available, whether it's locally, whether they're in another state, it all depends. So it is a situational by situational case and basis. So different scenarios can come into place, and different kind of references and referrals will be made based on the situation. But that is the most briefest way I can explain it.
That's great, Solimar. I remember from our training, I see Representative Carpino here with us. You and I went through that training together, and I remember that when you question very specifically, are you thinking of hurting yourself? Are you? And then when you persuade not just in general terms, but you say, let's go get help. Let's do this together, right? And then you refer 988, what a wonderful resource that you've reminded us of, the 211, but also some of those local resources. I'm really appreciative of the reminder in the chat of the Connecticut Suicide Advisory Board and all the great work that they've been doing over the last few years in helping advise some of our legislators, not only of some of these resources, but how agencies are working together with communities to help with interventions and supports. So thank you again, Solimar, for all that really thoughtful presentation. I'd like to open up the floor now for reflections from our leaders. And I'm going to start, I'm going to just kind of recognize you as I see you. Representative Carpino, thank you so much. In a lot of ways, we've worked together on these issues for so long, and your inspiration this year for us to continue to do this work is partly the reason that we're here. So welcome, Representative Carpino.
Thank you, Stephen, and thank you to all of the panelists who shared not only their professional expertise, but their personal stories. We've heard some staggering statistics, but I'm going to be really honest with the group, but even one loss of life to suicide is too many. To get a heartbreaking phone call from a family member who's lost someone is too many. And we could talk for hours here, but I think the most important thing that we've covered is the services, that we are social creatures, and each of the panelists hit on it in their own way. It's community, it's checking on one another, it's not being afraid to ask that difficult question if someone is struggling, or even if you have a hint that someone's struggling. And 988 is a wonderful resource, and Solimar put up a host of resources, and there's so many out there, but it's not being afraid to ask that difficult question, and not being afraid to step forward so that even one individual can be saved. So thank you for putting this together. And there's more work to be done. We need to make sure that everybody out there knows the resources available so that we can do our best not to lose another community member.
Thank you, Representative Carpino. Part of what we're going to do is some of the resources that you saw in that presentation, we're going to include in links, not only with this broadcast and on this page, but also on our website. We'll have some of those links so that they can be easily accessible. So thank you for reminding us of the importance of those resources. And while this is the month that we're focusing on suicide prevention, this is everyday work, and it's in every community, in every single community of the state. We've been reminded of that so starkly in the past couple of years. So thank you. Next, we do have, I'm going to call on Representative Kennedy after we hear from Sonia Carriam. Hi, Sonia.
Hi, I just wanted to echo what Solimar said. I'm from United Way, and I take the calls coming into 988 or 211. And the big push for us this month and beyond when 988 came out is that you can get the same services from 988 or by calling 211. The 988 is a number that is just supposed to be for everybody. So if you don't know where to call, you can call. But also when you talk about the number, when we take the calls, that's our goal, if we can save one person. So I think the statistics are so important, and it speaks volumes. And then our goal every day is like, if we can help that one person to lead them to help or get the services, that's why the statistics go along with, the help that we try to give.
That's wonderful. And whether it's 988 or 211, I love the fact that they're numbers that can resonate in our brains for that moment when we need them most. And it's something that we can remember and just dial when we're feeling that moment of despair or when we know someone who needs help. So thank you again to the United Way for all of that work that you do in linking us together through that resource. Representative Kennedy.
Thank you, Steve, and it's a pleasure to be here. I just want to thank each of our expert panelists. I'm looking at some of the notes I took, and it's staggering. And as Representative Carpino said, when you said it, Steve, just one death is one too many. I actually thank you, Dr. June. I really wasn't as aware of how many elderly suicides there are, but I think what hits me the hardest, and we talked about so many different ways and trying to recognize, but there's many times when we don't recognize that child, that young adolescent that's going through something and we're not seeing it. And I don't know how to get past that. I guess that's my hardest thing. In my community, we've had several suicides over the last 2 years. This month being the anniversary of someone dear to me. And I don't know that we saw it. So I guess that's like one of my questions to the experts. Sometimes maybe we're just not seeing it, or are we not? Are we missing something? And how do we approach that? So, but I'm just throwing that out. But I just want to thank you all again for so much. There's so much to look at, so much to read. I was looking at all your statistics, kind of looking up a few other ones, and it's amazing. I looked at a few states, Wyoming being the state with the highest level of suicide, followed by Alaska, Montana, Oklahoma, and Utah. It's mind-boggling.
Isn't it amazing, Representative Kennedy, how, we talked about some of those co-occurring situations, whether it be adolescence and puberty, whether it be special populations, children in special circumstances, whether it be people experiencing either traumas or a sense of isolation and difference, all these things coming together in various ways. And I think what's compelling to me about some of the statistics that we heard and the situations that we heard is that as the public, as people in community, as people in our own families, we can start looking for some of those hallmarks, those moments where we might see those blips and dips of people experiencing despair, and again, question, persuade, and refer. So that's the key. Is you're right. Sometimes who would have thought that there was another blip, another jump in suicidal ideation and completion among the elderly? Those are things we're not used to talking about. Who would have thought that that the trauma of poverty or the demands of success could be also moments that could lead someone to feeling isolated or despair? So thank you for that. Representative McCarty.
Whoops. Thank you very much, Steve. And I too would just like to add my remarks that during Suicide Prevention Month, I think this is very important that we have this discussion tonight. And also to say thank you very much to all of the presenters. I think we all learned quite a bit tonight. And what I took away from this is that we still need to do a lot more education on all of these different areas that we spoke about tonight. But to lend a little bit of hope, I wanted to mention to Andrea, I'm not sure if she knows that we worked diligently this past session on the Essential Caregiver Program for Connecticut for our seniors. And I think that really speaks to one of the areas that you talked about, the disconnection, that we never want to put our elderly population in a position again where they don't have human contact and they can't see their loved ones, because I think tonight we really heard the message loud and clear that this is about humanity, caring for each other, knowing where everyone is and really addressing them at that part in their life. So I just wanted to share that. I know there's a lot more work to be done with our seniors, but I also wanted to comment that some of the other, we need to do more education within our own legislature on some of these areas that are really impacting our children and the LGBTQ community. To see the high percentages, it was staggering tonight to learn some of those statistics. So I think we need to come together, talk to each other more, communicate, and really find the appropriate answers. I would welcome, Steve, if it's all right with the presenters, for them to send some, you know, we can't do it all at once, but send some where they would see their top priority, what we can do. I mean, we heard a lot about barriers with language and cultural barriers. And I think some of that has to take place at the community levels with those specific groups to help erase the stigma that's attached with talking about the issue, with being willing to share that. So but whatever we can do, I want to pledge tonight that I'm there to do what I can on the education committee. You know, we're looking at the bullying statute. I think that will go a long way, the social emotional learning. So we are making progress, but there's a lot of work to do. And if I may have a personal privilege, I would like to recognize Ann Daigle tonight, who is with us. This individual has done so much in our state and our community to build awareness, to give the message of hope and healing to individuals with her own resources, started her own grief counseling area. And I just hear throughout our region how many people depend on Ann Daigle, more like her in our state, and we're gonna make this progress. So I do wanna thank you, Steve, for always being in the forefront, finding what we need to do, how we can do it, and for inviting me to be part of the conversation. I appreciate it very much.
Thank you, Kathleen. And I wanted to give a shout out to Ann Daigle as well. One among several people, community members in Connecticut that rise to the challenge, you know, and, you know, when we think about Mui Mui and Regina, when we think about, you know, our work together over the years, how it's buttressed by a community that's across the state, different parts of community, whether they experience personal loss because of personal loss or because of community loss. And it's really, you know, it just resonates with me that we are each other's best protective factor. And whether it's through a formal way of QPR, questioning, persuading, and referring, or those informal ways in which we just, if we see something, say something, call someone, 988-211. That's really how we can be each other's best protective factor. So thank you again for highlighting that. I was getting a text from Representative Nicole Claudia that she's listening, but she can't join us to say goodbye, but wanted you to know that she appreciated the experts and the data. And also thank you to Representative Cook and Senator Maroney, who were here earlier as well. Again, thank you all for joining us tonight to, again, bringing these statistics to the fore. And to quote Solimar from earlier, this isn't just about the data and the statistics. They're important to lead that way so that we know where to look, but it's also about the resources. We have to have a yes and conversation when it comes to intervention. The resources are critically important. And I want to thank all of you for the great work that you do in saving lives. This is life-saving work, and you're part of it. So thank you all. I'd like to leave a couple of minutes for my co-chair, Alan Tan. I think he has a few words as we start to leave each other tonight.
Hi, everyone. I wanted to take a few closing moments today to reflect on everything that we covered in today's virtual forum. So suicide and mental health is no joking matter, because in these difficult times, you know, it's really important to be able to understand these issues and how to address despair within our communities. Those of you who do know my personal story will know that the issues like this motivate me to serve. It's very important for all of us to realize that together we thrive and divided we fall. We need to keep our community strong, and that means taking care of those who need our help the most. On behalf of the commission, I'd like to thank you all, especially TJ, Steve, and the staff for putting this together, our commissioners that were here today, the presenters, and of course, the legislators today who were able to join us for this important discussion for attending today's virtual forum. We hope that everybody who attended today found this very informative. So Steve, you know, I wanted to give you the opportunity to close out the event, and thank you all again for joining us.
Thank you, Alan. And I know that you asked to give some remarks because this is very personal to you. I think that what we'll find is whether we've lost someone in our own lives, someone next door, or someone down the road, this is very personal work for all of us. And I want to thank you again for everything that you do. Question, persuade, refer, 911-288. We can't say it enough. Thank you all and have a wonderful night.